Thank you. I want to congratulate Dr. Fernandez-Miranda on this entire meeting. It's absolutely stunning what we put together, and I think for all of us, we learned from each day of this, and I encourage everyone to watch all of the sessions, both this weekend and next weekend, as I know I'm doing and will be doing. I've been given the task of talking about endoscopic endonasal and extended middle fossa approaches. I'm going to focus just a little bit on the Petrus, because I think there are aspects of each approach which aren't really a crossover area, but I think this meeting and today's especially has done a beautiful job of showing the complementarity between the different approaches, and I think that that's a very important aspect of it. Just brief disclosure is not relevant to this discussion. As Juan mentioned, endonasal and transcranial are not versus each other, but rather are two approaches that we should all have available to ourselves. The area of the Petrus bone and Petrus apex is a challenge for all skull-based surgeons, regardless of which approach you take, given its multiple neurovascular structures surrounding that area and the difficulty and depth in reaching it. This is the classic area that we're used to accessing through an open approach of the Petrus apex. And of course, this is an image by the great Rhoton. The Petrus apex, though, can be approached from many different approaches, not just an open transcranial approach. And I think it's important to understand the different ways in accessing that. The endonasal approach to the Petrus apex can be a very direct approach. I think most of us started using this for cholesterol granulomas as a very nice option to access it. But understanding how do you get to that area, how do we get to these so-called coronal plane areas is very important. And for the so-called transpterygoid approach, we're talking about accessing through an extended maxillary antrostomy. So the maxillary sinus really becomes your window. We can do everything in endoscopic medial maxillectomy to have very wide access. And the more of that anteriorly you come on the medial maxilla, the more lateral you can access in the infratemporal fossa and middle fossa. These are the steps of the transpterygoid approach. They include that maxillary antrostomy, and then you have to deal with the sphenopalatine and the pterygopalatine space, and then finally drilling the base of the pterygoid. Important to understand the contents of the pterygopalatine fossa. If you're not concerned about preserving vascular pedicles, we just have to make sure that we can control the IMAX, and many times perhaps a preoperative embolization is a good option. But it's really critical to understand the infraorbital nerve, which you see here coming, V2 coming into the infraorbital, and the descending palatine branch to avoid deficits for the patient. Here we can see initial access to the sphenoid and maxillary antrostomy, where the sphenopalatine, and here we see the palatovaginal artery extending inferiorly to the nasopharynx, which is a beautiful landmark to the Vidian. Once we open up widely the posterior wall of the maxilla, again, we're looking on the right side, the posterior wall of the maxilla here has been removed. We can then dissect through the pterygopalatine space and start to see here coming into view the infraorbital nerve. And then dissect out the pterygopalatine fossa. Here we see a large IMAX branch. This can be coagulated or dissected laterally. And here we see the infraorbital branch and then descending palatine, which will be critical to preserve if we want to preserve palatal sensation. This is a view more from a medial approach. Here we can see the sphenoidotomy and the so-called pterygoid wedge with the Vidian nerve at the base of the pterygoid wedge as a beautiful landmark for many of the critical aspects, including the horizontal Petrus carotid artery. Understanding the relationship of the pterygopalatine fossa and the pterygopalatine contents to the pterygoid base and the pterygoid plates is key to understanding the transpterygoid approach and also trans-Petrus approaches. Even perhaps more important is the Petrus internal carotid artery. Again, in this other beautiful view from the Rhoton collection, if you see the different segments of the Petrus carotid artery, they define our access to the Petrus and the parasagittal planes. Of course, the main segments are the parapharyngeal, the horizontal Petrus, the paraclival, and the paraclinoidal segments of the carotid artery. These are the different landmarks that I use. Of course, the paraclinoidal has a so-called medial OCR, which is the keyhole to the endonasal paracellular craniotomy. And then the anterior genu of the carotid at foramen lacerum, that medial pterygoid wedge really points directly back to that anterior genu. And then finally, the Vidian nerve crosses over the horizontal segment and the eustachian tube attachment leads back to the ascending or parapharyngeal carotid artery. These landmarks are critical for understanding this area, but as we start to get comfortable working around the paraclival carotid artery, we can understand that immediately posterior to it lies the Petrus apex and the Petrus bone. This is really the key. It often is accompanied by a transclival approach, and you'll see in contrast to an open extended middle fossa approach, endonasal gives us the medial portal to the transclival and then transpetrous approach. Like with open approaches, there is a triangle that we can use to access the Petrus bone and the Petrus apex here. The boundaries of this triangle are the sixth nerve, anteriorly the paraclival carotid artery, and inferiorly the petroclival synchondrosis or fissure. And working in this area can give us really very wide access. Many tumors grow and expand this triangle to give us access into the Petrus bone. Here's an example of a chondrosarcoma we see on the scan there on the left, and we're using that triangle to access the Petrus apex and the Petrus body, and that's what really gives us access to resect completely this tumor. Here's an example of a recurrent cholesterol granuloma that Dr. Fernandez-Miranda actually did, and showing the beautiful access, again, behind foramen lacerum, between the petroclival junction, below the sixth nerve, and posterior to the horizontal or vertical or paraclival carotid artery. Here he is removing a stent from that space. And this is a multiply recurrent cholesterol granuloma. But we can see here how this access through the triangle into the Petrus bone gives us a beautiful access to completely drain this cyst. So here's an example of a relatively simple access to the Petrus through endoscopic endonasal approach. By comparison, an anterior transpetrosal or an extension, again, I'm going to focus on the aspect of the middle fossa that relates to the anterior Petrus bone, because really an endonasal approach doesn't have good access to the IAC, doesn't have good access to the arcuate eminence, and so it doesn't become as relevant as those are areas that are clearly owned by an extended middle fossa approach. Of course, this starts with either we can use a more extended approach like this or the more minimalistic incision that Maria showed earlier. Interfacial dissection, understanding how to preserve the frontalis branch, is of course a critical part of any approach here. If we want to come more anterior or anterior pretemporal, sacrificing the meningoorbital fold to have access to peel the cavernous sinus is a key extension of this. But in the end, the access we're looking at is by peeling Meckel's cave, having access to the middle fossa floor, all the way from the arcuate eminence to foramen ovale. This then gives us access to the classic triangles, and here we can see, of course, the rhomboid for the modified Dolan-Kawase rhomboid that gives us complete control of the Petrus apex from this extended middle fossa approach. And here's the drilling of that extended middle fossa, exposing the carotid artery, drilling just anterior to the IAC, and all the way back to the posterior fossa. Once the superior petrosal sinus is ligated and the tentorium cut, we can have access all the way from the posterior fossa, from the IAC anteriorly up to the porus trigeminus. And this really is the beauty of this approach, is this most lateral access, as well as access to the superior aspect of the Petrus apex. Here's an interesting case, a multiply recurrent meningitis, where this meningoencephalocele kept leaking endonasally into the nasopharynx and oropharynx. And she had undergone a standard temporal craniotomy because this was thought perhaps to be a tegment defect, but it's really not. She'd also undergone an endonasal repair of the lateral sphenoid, but it wasn't leaking there. And it turns out this was leaking through the posterior aspect of Meckel's cave from the Petrus bone, and then eventually percolating back into the eustachian tube. So I thought because she had failed multiple attempts, we really should do a middle fossa approach to give her a give me maximal access to the root of this meningocele in order to be able to pack it off. We're using this extended middle fossa approach, drilling out. I think a nice trick here is to completely decompress V3. Here we're, of course, sacrificing the meningoorbital band to start our peeling of the cavernous sinus. I think this gives us a little better ability to gently retract the temporal lobe if we do this initial dissection. It also gives me a nice view of the attachments of V2 and V3 so I can peel Meckel's cave. Here we are dividing the middle meningeal artery. You often want to do this in the most controlled fashion possible, but now we see foramen spinosum. We start to peel Meckel's cave. And this gives us complete access now to the middle fossa floor, Meckel's cave. Here we can identify GSPN with a cartouche dissector, sharply dissecting and disconnecting the dural attachment of the periosteal dura to V2 and V3. And oftentimes here, I'll just coagulate back the dura and let the dura do the retraction. You can see I don't use a static retractor in a case like this until I get to the point where I need to drill the anterior petrous bone. Here we can see our landmarks for the petrous rhomboid. We can see how actually this meningocele has worn away. Now the repair previously was simply done by placing a bit of tissue on top of this, but the true defect is actually deep and posterior. So by doing this kind of a dissection on the posterior aspect of V3 into this meningocele, which is really extending into the posterior fossa, and here I'm using endoscope assistance along with this basically petrosectomy that's been performed by the meningocele. It allows me to visualize the porous trigeminus, and then I can pack this off completely with muscle and fat to ensure that I seal the leak. I chose relatively simple cases for both of these just to show conceptually the access. And hopefully if we have time, I can review some cases later to get the group's opinion as to different ways that they would approach different cases from open versus endonasal approaches. Approach selection really should vary, not just by the location, but by the pathology and the goal of surgery. So different pathology have different goals. A clusteral granuloma, I just want to drain it. Something like a chondrosarcoma, complete resection is critical. And then petroclival meningiomas, I think really require often subtotal resection to allow for neural preservation. The petroclival region also is impacted by this. Chondrosarcoma that classically arrive from the petroclival synchondrosis and extend into the petrous apex. Again, here we see this medial triangle, which has been dramatically expanded by this tumor all the way to the clival dura. And we can peel the tumor out completely. In the interest of time, I'll cut through and just show the final result of this. But here we can see the sixth nerve anteriorly, paraclival carotid artery, we've been dissected completely, and the petroclival synchondrosis inferiorly. And here we're using a sonopet to remove a portion of the involved petrous apex to ensure radical resection, removing dura below the porus. And we'll see the fifth nerve come into view at the end. Here we see the fifth nerve going out into the porous trigeminus. So the exact same kind of view as we have from that open approach, but better access to the clival region as opposed to access to the IAC. Chondrosarcomas, of course, require every possible approach. And you see even in our series, a fair number of these require a craniotomy. Here we see the outcomes of that for petroclival. Now, where do we have residual with endoscopic endonasal approaches? Where larger tumors can be more challenging, but especially involvement of the middle cranial fossa, the lateral aspect of the cavernous sinus, and the CP angle, all of these sort of make sense and are clearly complementary to an extended middle fossa approach. Many of these, as I mentioned, require staging with a secondary or a primary craniotomy. As all of our friend Jacques Morcos reminds us, craniotomy is not a bad word and should be part of the armamentarium, as all the other speakers have mentioned. Here's a large petroclival meningioma that we managed endonasally. A relatively young man with progressive gait difficulty and some cognitive dysfunction from early hydrocephalus. Very large tumor blocking his third ventricle outflow and significant brainstem compression. I think I will skip this in the interest of time, but here you can see our goal here is not a radical resection, but rather perhaps a two-stage management where we initially decompress. This was done, decompress the endonasal portion and then do an open approach for a more radical removal. Here we can see a wide clivectomy. An inferior rhinopharyngeal or RP flap for the clival access. And here we see the wide clival resection. We can do an initial debulking of the tumor, identify the sixth nerve, and then debulk the tumor. Now to continue with the debulking of this, we have to do the pituitary transposition that Dr. Fernandez-Miranda has so elegantly described. I would encourage everyone to look up this technique as well as his work on cavernous sinus, put a tremendous amount of effort into this, but it's a beautiful example how we learned from the lab and are able to transition this into patients. So performing clinoidectomies gives us access to the superior pole of this tumor as well as the perimesencephalic cisterns. We can then access now along the sixth nerve, we can access into this medial Petrus triangle, but also transcavernous above the sixth nerve between the third and sixth nerve. You can see that looking up with an angled endoscope between the third and sixth nerve to get a relatively complete resection, at least up to the posterior clinoid and the Petrus bone. Here's the final view. And I'll skip ahead to the imaging. Here we see obviously the portion left on the Petrus bone, and this could be managed from an extended middle fossa approach to get a near complete resection of this tumor.
That's an awesome resection, I must say.
Is mesial to all of these the neurovascular structures. It's a relatively simple concept, but important.
Did we lose you, Paul?
Extended middle fossa approach, ideal for that. We were able to accomplish this endonasally. Here you can see the post-operative view of exactly that. The infratemporal fossa extension can be done also through an anterior transalveolar sphenoid approach like you see done here, where we're extending through an anterior transmaxillary approach to decompress this V3 schwannoma. Again, I think I'll skip this in the interest of time with only the point that this is really only good for Meckel's cave and V3 schwannomas. If you extend back towards V1 or V2 or pure Meckel's cave, an open transcranial approach or an extended middle fossa approach really is a much better option for those particular tumors. Middle fossa can rarely be accessed also. Here's a patient with a multiply recurrent meningioma extending in the middle fossa. We did a Danker's extended maxillary antrostomy. Here you see sacrificing the Vidian, drilling out the pterygoid all the way out to foramen ovale. We can open lateral to foramen ovale, decompress the tumor in the posterior fossa as well as in Meckel's cave. Here's the, middle fossa as well as in Meckel's cave. And we're working on both sides of V3. Here's foramen ovale. And there's tumor all the way out to the temporal lobe and all the way into Meckel's cave. Reconstruction is important when we're looking at transpterygoid approach. You have to have the flap on the opposite side or you really can't do the transpterygoid because the flap mobilization can kill the flap. Leak rates, of course, are critically important, and the nasal septal flap has been a key part of that. Anytime we extend laterally, you have to be aware of a carotid injury. Here's a case of here's the periclival carotid artery working on a chordoma. And trying to extend, this is very early work where we didn't understand this Petrus anatomy well. I was also, I wasn't oriented in the field and ended up cutting right into the carotid artery here. You can see a periclival carotid. I had to sacrifice this. We did have proximal control in the neck and good back bleeding, so I was able to safely sacrifice this, but I had no other good option other than packing it off and hoping for an endovascular salvage. Fortunately, this child did very well because of her persistent trigeminal as well as ACOM collaterals. Again, can't emphasize enough as we extend out into the Petrus bone, an understanding of the carotid anatomy and the key landmarks for accessing and safely dissecting out this anatomy. We can also try to avoid carotid injury by avoiding manipulation of the carotid. This is a recent development. Dr. Snyderman came up with a contralateral transmaxillary approach, where rather than just a transnasal corridor, if you look at the CTM axis behind the horizontal Petrus carotid, we have beautiful parallel access to the Petrus carotid, and this allows us dramatically to increase our corridor for tumors like a chondrosarcoma. And this gets us much more lateral into the Petrus apex. So here, where we would normally go through a transclival approach, we would completely unroof the carotid artery and work through that triangle I mentioned earlier. Here's opening that triangle, mobilizing framum lacerum. We have a certain amount of access from an endonasal approach. So here I'm working with a suction, but without dramatic carotid lateralization, I really can't access it. But as soon as I start working through the CTM approach, through the anterior maxillary antrostomy, now my suction can work all the way out. Here we see the horizontal Petrus carotid. Our 45-degree scope is turned laterally and working all the way from Meckel's cave in the middle fossa, all the way down to the jugular tubercle, clearing out the entire Petrus body, even all the way out to the IAC. So beautiful example of how this, how these corridors and multi-corridor surgery can really allow us better access. Here you can see all the way out to the IAC and all the way down to the jugular tubercle and jugular fossa. I won't belabor this, but looking at using the CTM, we were actually able to get GTR in 75% of cases where the Petrus portion for chordomas and chondrosarcomas. Again, endonasal and transcranial really are very complementary. This is a study done by Vanessa Hernandez at when she was with us. A beautiful study comparing the access to the middle fossa and the Petrus apex by these various approaches: endoscopic endonasal, CTM, and an extended middle fossa, or Hakuba Dolenk Kawase approach. We did 3D reconstructions using CT scan. And looking at the amount of Petrus apex evaluated, you can see the Petrus apex from a Hakuba Dolenk, we have beautiful access to the Petrus apex. But if we do use CTM, we have almost the same access to the Petrus apex as we would from a Hakuba Dolenk. So if you look at the percentage accessed, it really is the same between a Hakuba Dolenk and a CTM, especially with carotid mobilization. If we look at the Petrus body, the main bottom part of the Petrus bone, though we really have superior access through the CTM, the Hakuba Dolenk can only reach so far inferiorly and lacks access to the clival portion. So when we look at the Petrus body, really the CTM, especially with carotid mobilization, provided superior access. So when we look at this, if you're looking at the Petrus apex, you really should consider an extended middle fossa approach, whereas if you're looking at lower down in the Petrus body, a CTM plus ICA seems superior. But this really shows the complementarity of the two approaches and understanding, just like Danny showed beautifully with endonasal versus anterior cranial approaches for the anterior cranial fossa, the same thing is true for the middle fossa. These two approaches really are complementary. It depends on their location relative to the neurovascular structures, but very importantly, depends on the surgeon experience. If I'm more comfortable with a certain approach, farther along in my learning curve, I'm more likely and should be more likely to choose that approach. Again, different pathologies also have different goals, and that should help determine our approach as well. Here's the neurovascular limitation for endonasal approach, and here's the learning curve. This is our own institution very early on. You can see these level 5 approaches at the bottom were never even attempted very early on, and that's a very important lesson. You can destroy your practice by trying to jump too far ahead in your own learning curve. In the end, if we look at this purely anatomically, an endonasal approach has advantages where we can come in medial to cranial nerves. We have access to the entire clivus, the medial cavernous sinus, and the Petrus body, but it's limited. You can't access the CP angle. You have trouble getting up to the Petrus apex, and the 6th nerve is inevitably between you and the Petrus bone, and you have to work around that limitation. Conversely, an extended middle fossa or anterior transpetrus approach has a clear advantage that we're lateral to cranial nerves. So meningiomas would be better accessed this way. We have the entire temporal fossa, Meckel's cave, and IAC, but we're limited below the IAC. We don't have great access to the Petrus base, and the 4th nerve is inevitably in our way. I do have some examples of cases, Juan, if you want to have a little bit of discussion, but I know we're running a little late on time, and I don't want to run into the other sessions.